So good morning, dear students. So today also I have compiled some of the clinical cases for you, some clinical cases and clinical scenarios. Okay, so let's discuss them. These are the important one. Rather than solving them, you have to focus on the explanation part here. That's how you learn a lot. But try to solve it before we go to the explanation. So just like last time, I will read some of the clinical scenario. If you have a paper and pen in front of you, you should write the important points to try to solve it and then synthesize the diagnosis. That is the one we're going to do. Okay, now see here. Please mute yourself. A 36-year-old man. See here. The patient's age is 36-year-old. Okay, man presented to the physician complaining of right scrotal swelling. So this is a case of scrotal swelling. We all know if any cases of scrotal swelling is there, we think of hernia, the inguinal hernia, or hydrocele, or testicular mass. Okay, like that. These are the common differential diagnosis. He states that the swelling has been present for just 1 week. He initially noticed the swelling shortly after moving furniture of his new living room. So probably there is increased intra-abdominal pressure while moving the furniture. And because of that, okay, the mass has appeared. You think like that. He denies any nausea, vomiting, change in bowel habit, abdominal pain, or urinary tract symptom. So probably there is no feature of intestinal obstruction. See this? No abdominal pain, no change in bowel habit, means no constipation or any diarrhea. He has no other significant medical or surgical history. That is, we always ask history like that. On examination, okay, he has an enlarged right hemiscrotum with a mass that appears to be originating at the level of external inguinal ring. Now, the mass is coming out from the external inguinal ring, that is called a superficial inguinal ring. Okay. Now, remember, in case of inguinal hernia, there are two types: direct hernia and indirect hernia. So the indirect hernia, enters the inguinal canal through the deep inguinal ring. It travels the whole inguinal canal and come out through the superficial inguinal ring. This is indirect inguinal hernia. Whereas the direct inguinal hernia appears from one triangle. What is the name of that triangle? Anybody?
Femoral triangle.
No, direct inguinal hernia appears from one of the triangles, not femoral. So another Hasselbeck triangle. Okay, Hasselbeck triangle. I'll talk about that later. Don't worry. Femoral hernia appears from the femoral triangle or femoral canal. With the patient completely relaxed, the physician is able to reduce the mass by pushing it back through the external inguinal ring. So this is called reducible hernia. Reducible. We can push it back. So that means it is not very complicated type of cases till now. With the mass reduced, the physician instructs the patient to perform a Valsalva maneuver. Okay, Valsalva maneuver will increase the intra-abdominal pressure so that if hernia is there, it will again pop out or the hernia will become prominent. That exactly happened here because the protrusion is felt at the external inguinal ring. Once the mass is reduced, the testicle appears normal in size and consistency. So it is not coming from the testes, because testes looks normal in size and consistency. Now, see there, such a long history and the case, but look at the question here. Which of the following is the most likely diagnosis? Okay, so after you go through the whole scenario and the question, this is one of the easiest answer you can ever pick. Now, what is the answer here? Hydrocele, femoral hernia, inguinal hernia, testicular cancer, or varicocele? What is the answer? Okay, exactly. We have already talked about this. Has to be inguinal hernia. This has to be the inguinal hernia. Look at the how you synthesize the diagnosis. That's what I want to teach you here. All of you can make this answer very easily, but how to synthesize the diagnosis. Look at the underlying what I have done here. These are called important points from the scenario and the case. Okay, you have to note these things and then think for a moment what this case is all about. We can easily reach to the diagnosis. So this is a scrotal swelling just for 1 week. There is a history of moving furniture, probably that has caused increased pressure and leads to herniation. Okay, the hernia has entered from the deep inguinal ring and coming out the external inguinal or superficial inguinal ring. It's a reducible type of hernia, so most of the things are there. So let's move on. Now, sometimes your teacher will ask this question to you: what are the differences between direct inguinal hernia and indirect inguinal hernia? Okay, so let's talk a little bit about that. Direct inguinal hernias occur through the Hasselbeck triangle. Now, Hasselbeck triangle is present on the medial side. Okay, now what are the boundaries of Hasselbeck triangle? Let me ask this question. Anybody? What are the boundaries? Any student? Okay, so let me write it here.
Yes, sir.
Yes, please. Yes, yes.
Sir, it have three borders, sir. Medial,
Okay.
lateral, and inferior border, sir.
Okay.
Inferiorly, there is a ligament, that inguinal ligament, which is formed by the external transversalis, external oblique muscle epineuritis, and laterally it is bounded by inferior epigastric artery vessels, and medially it is bound by rectus abdominis muscles.
Exactly. Exactly. It's absolutely correct. Hasselbeck triangle has to have a three different borders. Okay. On the lateral side. On the lateral side, these are inferior epigastric blood vessels on the lateral side. Inferiorly, there is an inguinal ligament, and medially, okay, this is a lateral border of rectus abdominis muscle. So it exactly acts like a triangle there. And through this Hasselbeck triangle, the direct inguinal hernia occur. Never forget this. It's a very, very important question from the anatomy and also from the surgery. Whereas the indirect type of inguinal hernia, it occurs through the deep inguinal ring. And what structure is separating these two structures is the inferior epigastric vessel. So medial to the inferior epigastric vessel is direct hernia, and lateral to the inferior epigastric vessel through the deep inguinal ring, this is indirect inguinal hernia. Okay, so this is the important point. Now, other things are quite easy for you. Now, there are three different types of herniation. Okay, according to the characteristics, we call them reducible hernia, irreducible hernia, also known as incarcerated hernia or obstructed type of hernia, whatever name you want to give there, and then strangulated hernia. Among them, strangulated hernia is the most serious one because there is no blood supply. The content of the hernia is already dead. This is ischemic necrosis. So the treatment has to be quite quickly. We need to resect that mass or that content and do end-to-end anastomosis. Usually a small piece of intestine is dead there. That is called strangulated hernia. So please prepare well about the hernia topic. Let's move on. Now, this case is the same one, exactly same one. Okay, so I'm not going to read the whole case with you, but only the question. Look at the question, how the question can be asked from the same case. See here. Which of the following nerves travels along the spermatic cord within the inguinal canal and may be damaged during a surgical procedure to correct this patient's condition? So, straightforward question. Which nerve is there in the inguinal canal along with spermatic cord? Yes, even without looking at the option, you can pick the answer here. Yes, which nerve is that?
Ilioinguinal lung.
Exactly, ilio-inguinal nerve. Okay, everybody know that because we have already done this before. Ilio-inguinal nerve is the content of inguinal canal. In case of male, spermatic cord and ilio-inguinal nerve. In case of female, ilio-inguinal nerve and which structure is there in female inside the inguinal canal? In female,
Ligament to the
yes. What is the name of that
some
ligament?
uh,
Round, round
round ligaments.
ligament. Exactly, round ligament of the uterus. This is known as round ligament of the uterus because there's no spermatic cord in female, you know. So in the place of that, round ligament of the uterus and ilioinguinal nerve. It's a very easy question, but look at the length of the clinical scenario. So sometimes what the student do, oh, it looks so long, it looks so complicated. So how can I solve it? Don't ever think like that. Slowly go through the case and look at the question what they have asked. Usually the answer is pretty simple here. Now, see this. The correct answer is B. Okay, let me go through this because this is how we learn here. The answer is B, that is ilioinguinal nerve. Although it is now possible to perform inguinal hernia repair laparoscopically, the traditional approach is through an incision over the inguinal canal. So while you are giving incision, you can damage the ilioinguinal nerve. Okay, that is the main problem here. All other nerve which are given there, like iliohypogastric nerve, lateral femoral cutaneous nerve, obturator nerve, and pudendal nerve, they are not even associated with inguinal canal. So these are the wrong options. Please mute yourself. So let's go to the number 3. It is again the same case, absolutely the same one. But look at the question, what they have asked. Which of the following pathological process might cause the patient's underlying condition to occur in an infant? You see this. If this process occurs in infant, which pathological process might cause, okay, or is responsible for the underlying condition? And they have given different options for us. One, or A, is defect in the floor of the inguinal canal. B, defect in the internal inguinal ring, also known as deep inguinal ring. Defect in the linea semilunaris, okay, linea semilunaris, it is the border of rectus abdominis, patent processus vaginalis, and persistent lumen of the tunica vaginalis. So which one is the correct option here? I'm sure you have got the question. If an infant, okay, gets inguinal hernia, what mechanism is responsible for that inguinal hernia? That is the question here. Anybody?
D.
D. Okay, can you explain why?
So that processes vaginalis provide the connection between peritoneum and the scrotum. So if that doesn't close and remain patent, so the connection will also be remain, and the content of abdominal cavity can easily protrude scrotum.
Exactly, exactly, absolutely. Correct explanation he has given. This is the D, patent processus vaginalis. Now, processus vaginalis is a is a part of peritoneum. It's a part of peritoneal membrane which is descending downward, along with gubernaculum. Now, remember, gubernaculum is a fibrous cord which is attached with the testes, and because of this gubernaculum, testes will descend downwards, and testicular descent is complete, okay, at the time of full term. Full term, never forget this. So if a baby is born preterm, testes is still in the inguinal area or sometimes even in the abdominal cavity. It depends on how preterm the baby is. Okay. Now, along with that gubernaculum, anterior to the gubernaculum, a piece of peritoneal, a fold is also descending downward, and that is known as processus vaginalis. It should cut off. Otherwise, there is a high chance of inguinal hernia in case of infant. So this is also very easy question. See there? The correct answer is D. The pathological process that causes hernias is different in neonate and infant than in an adult. Embryologically, in the 7th week, the testes begin descending from the location at the 10th thoracic level into the scrotum. After the 8th week, a peritoneal evagination called the processus vaginalis forms just anterior to the gubernaculum. The function of the gubernaculum I already talked about. It drags the testes downward. Okay, and this is the fold of peritoneum known as processus vaginalis, which is responsible for inguinal hernia in these small babies. Let's move on. Now we move on to the new case. Okay, all these are the related questions from the same case. So let's move further. A 2-year-old child, you see the age of the child, is seen for a well child visit in a pediatric clinic. Well child visit. Not serious problem is there from the family side. Abdominal examination demonstrate a palpable non-tender mass on the left side of the abdomen. These are the important questions. Palpable non-tender mass on the left side of the abdomen. The mother had no idea that the mass was present. So mother could not even found it, probably during the taking care of the baby. She was not even palpating it. That's why she never brought the child, to the doctor. This is a well child visit, means we often tell the family, take your baby, to the pediatrician during the vaccination or immunization. They have to come for that. And during that time, we take the opportunity to examine the baby quickly. Okay, that type of examination has picked up this case. Now, see there, the pediatrician did not note the presence of the mass at the child's 18-month well child visit. So at 18 months, even the pediatrician did not notice it. Probably the mass was not present there, but at 2 years, the mass is present. So that is a duration of the mass. Physical examination is otherwise unremarkable. Now, one small question to you. So what type of mass you think is this? Anyone? What is the cause, or what type of mass is this?
Sir, I
Tumor.
think, sir, this is
Okay, one is tumor. Yeah, it can be a tumor. Anything else? Let's think broadly. Okay, tumor is one of the most common mass, but not always. It can be a cyst. It can be a malformation.
Maybe
Isn't it?
hydrocephalus.
Okay, so see there. So these are hydronephrosis, right? You mean hydronephrosis? Not
Sorry,
yeah,
hydronephrosis.
hydronephrosis, definitely. So these are the different masses. Is right. So this is the way you think. Maybe this is a tumor. Maybe this is a cyst. Maybe this is a hydronephrotic mass. Maybe this is some type of malformation during the development. Now look at the other clues here. See that, please. If a CT guided biopsy, okay, if a CT guided biopsy of the mass were performed, which of the following histological pattern would be most suggestive of the likely diagnosis? Now, this is a little bit difficult case for you because they have not even given the clue for the diagnosis, and they have straight away asked the histopathology. Now, one important point I like to highlight here, at this age, Wilms tumor is one of the commonest tumor which occurs in the child. Wilms tumor, also known as nephroblastoma. So, is there any clue for nephroblastoma from the list or not? Let's find out. Cords of clear cell with rounded or polygonal shape and abundant clear cytoplasm. This is not the hallmark of Wilms tumor here. This occurs in renal cell carcinoma. Okay, renal cell carcinoma, which is usually seen in adults, not in children. Invasive papillary lesion with delicate connective tissue stalk covered with epithelium resembling that lining the bladder. Now, this cannot be the mass because it is present in the left side of the abdomen and bladder is present in the hypogastric area or suprapubic area. This is transitional cell carcinoma. A small dark cell embedded in a finely fibrillar matrix with formation of numerous rosette This rosette formation is the hallmark of neuroblastoma. Neuroblastoma occurs in a relatively younger baby, still younger than that. Triphasic pattern with tubule formation, spindle cell, and blastemal element. This is the histopathology of Wilms tumor. This is triphasic pattern. It's three different types of tissues, tubular epithelial tissue, which exactly forms like a tubule of nephron, spindle cell, and blastemal element. So this is Wilms tumor histopathology. And then the uniform sheets of small round cell with scanty cytoplasm. This can be seen in so many different tumors. These are called small round blue cell tumor, like neuroblastoma, like non-Hodgkin's lymphoma, rhabdomyosarcoma, even retinoblastoma. So the answer is D here. So sometimes, questions are a little bit difficult, but the point here is we are learning about the histopathology of Wilms tumor in this case. Now, see there? Let's go through the explanation. The correct answer is D. Adequate sampling of most Wilms tumor will detect the three distinct growth patterns that are most characteristics of this tumor. Less cellular tumor areas containing spindle cell, which is one. Densely cellular or blastemal area are there, okay, and they are having darkly blue nuclei, and there are areas with production of more mature appearing epithelium, which may form occasional tubules. These are the three components: spindle cell, blastemal areas, and tubules. The tissues present are similar to those present in the developing kidney. That's why it is known as nephroblastoma, and it may include primitive glomeruli as well. So these are the important points. Sometimes it may have some other types of tissues as well, but these are quite rare. Now, choice A suggests renal cell carcinoma, choice B suggests transitional cell carcinoma, choice C suggests neuroblastoma, and choice E suggests Ewing sarcoma or neuroblastoma or even non-Hodgkin's lymphoma. So you have to prepare for this type of cases also. Sometimes questions are asked like this. Let's move on. Let's solve the number 5 case. So let me go through it again. A 2-year-old child is seen for a well child visit in a pediatric clinic. Abdominal examination demonstrated a palpable non-tender mass on the left side of the abdomen. Same case again, absolutely same. But what question they have asked? So you already know this is a Wilms tumor case, okay? So see this? Children with which of the following abnormalities at birth should be monitored for the development of this disease? So there are certain developmental abnormalities given here, but which one is associated with Wilms tumor? That is the question. Aniridia, coarctation of the aorta, cystic hygroma, parathyroid hyperplasia, or simian crease. Anybody wants to take this opportunity?
Option A, aniridia.
Aniridia. Okay, both of them are saying aniridia. Why?
Sir, because Wilms tumor can be a part of Wagga syndrome, which stand for W stand for Wilms tumor, A stand for aniridia, and G stand for genital abnormality, and R stand for mental retardation.
Excellent. Excellent. That is the knowledge which we want to discuss from this case. Very well explained. This may be a part of Wagga syndrome. Wagga syndrome. Okay, W stands for Wilms tumor, which is the case given here. Okay, that A belongs to aniridia. Aniridia, lack of iris. Iridia is the iris tissue, which is present in the eye. Iris is a part of middle coat of the eyeball. Our eyeball has 3 coats. The outermost coat is called sclera with cornea. The middle one is called uvea, and the inner one is called retina. Now, uveal tract has again different parts. Choroid is the most important one. okay, followed by iris and ciliary body. Ciliary body, iris, okay, and the choroid. So lack of that iris, or absence of the iris, is not aniridia. So the pupil look very irregular there. Anyone can detect it from a distance. But when we compare between the two eyeball, something is wrong in that aniridia side. Now let's see the explanation here. Please mute. The answer is A here. Okay, the answer is A. Now see this. The Wagga syndrome, WAGR, Wagga syndrome include Wilms tumor, aniridia, that is lack of defect of the iris. G stands for genital anomaly, which may be gonadal dysgenesis, means gonad are not properly formed, hypospadia, Kryptorchidism, or other genitourinary anomaly. Now, what is hypospadia? Anyone?
Sir, it is the opening of the urethra, like at the shaft of the penis downward.
Okay, you're right. You're absolutely correct. This is a ventral opening of urethra. Okay, the external urethral meatus is present on the ventral side of the penis. Usually it is present right at the tip, but in this case on the ventral side. Sometimes it may be present on the glans penis, sometimes on the shaft, and very, very rarely it is even present on the scrotum sometimes. This is hypospadia, one of the important congenital anomaly of the penile area. If it is present on the dorsal side, we call it epispedia. Okay, epispedia and hypospadia. Don't forget that. What is Kryptorchidism? Kryptorchidism.
Undescended.
Exactly. Undescended testes. The medical term is Kryptorchidism. Sometimes it's unilateral and sometimes it is bilateral. Usually, it is bilateral. So these are the terms which comes under genital anomaly, and R stands for mental retardation. So this is Wagga syndrome. Wilms tumor can also occur as a part of Beckwith-Wiedemann syndrome. Now, let me say a little bit about Beckwith-Wiedemann syndrome. Now, Beckwith-Wiedemann syndrome presents with hemihypertrophy. Please mute yourself. Hemihypertrophy, okay, is one of that, and hypoglycemia is the another one. Now, Beckwith-Wiedemann syndrome, babies look quite bigger than the other baby. Okay, if we examine closely, there is one side of the body which is hypertrophied than the other, and the same baby may present with intractable and recurrent hypoglycemia. So if we fail to identify this baby right at the time of birth, then this baby will definitely develop hypoglycemia. And we may think about so many other things. We may take a good history. Maybe the mother is diabetic or not. Okay, what is the gestational age of the baby? Something like that. But this is a Beckwith-Wiedemann syndrome, and the same syndrome may be associated with Wilms tumor development later on. Another is known as Dennis-Drash syndrome, or simply Drash syndrome, which exists as a nephropathy and ambiguous genitalia. Now, what is ambiguous genitalia? What is that?
We cannot differentiate the gender by just looking to genetics.
Yes, you're right. Okay, this is a case of hermaphroditism. Hermaphroditism. There are different types of hermaphroditism. One is called true hermaphrodite. Another is called pseudohermaphrodite. Now, let me take this opportunity to explain a bit of point here. True hermaphrodite means, okay, both gonad are present in a single person. Ovary and testes, both are present on the single patient or person. So these are true hermaphrodite. Whereas pseudohermaphrodite means the genetic sex is one and the phenotypic sex is the different one. Phenotypic means what we see from outside. That is the genitalia, the external genitalia. It looks ambiguous. Now, let me take an example. If the genotypic sex is a male, okay, is a male, but phenotypic sex looks like a female. This is a typical case of ambiguous genitalia or male pseudohermaphroditism, and vice versa. If she is a phenotypically female, but genotypically genotypically female, but phenotypically male, then also we call it female pseudohermaphroditism. Now, students are a bit confused here. What term we use? Is it based on the genetic sex or the outer, genital appearance? It is always according to the genetic sex. Never forget this. What is the chromosome? What type of chromosome? If there is a Y chromosome present, that person is a male. Whatever happens to the external genitalia, we don't care. This is a male. If the genetic sex is, 46XX, for example, then she's a female, even if the external genitalia looks like male. And that's why it is known as ambiguous genitalia. This is an interesting part of the medicine. Let's move further. Some other points. Coarctation of the aorta and cystic hygroma, they are very important association are associated part of Turner syndrome. Turner syndrome. Remember, this patient is a girl. Okay, she is a girl. And what is the karyotyping of Turner syndrome?
45X.
Excellent. 45X. One X is deleted there. It is 45X. So these are the important questions for you in the exam. Please have a note, which may predispose for later development of ovarian cancer as well. Now, parathyroid hyperplasia, which is given in choice D, can be accompanied by multiple endocrine neoplasia or MEN syndrome. Now, MEN syndrome are of different type. Type 1 and type 2. Type 2 are also 2A, 2B like that. Okay. So MEN syndrome has pituitary involvement, parathyroid involvement, and pancreas involvement. So because of parathyroid hyperplasia, it is a part of MEN syndrome here. So this doesn't have any relation with our case. And simian increase is a feature of Down syndrome. Now see it, okay? Again, the same case, absolutely same. But see what question they have asked. Different question. Abnormalities of which of the following chromosome have been linked to this disease? So they have asked the chromosomal abnormality now. So this is a bit of a difficult question. If you have not studied this well before, the answer is chromosome number 11. Okay, it is 11. Now see this? The correct answer is C. Inactivation of the Wilms tumor 1 gene, which is located in 11p13, short arm of 11. So this is the important point here. Another one, a 67-year-old patient, which is a male patient with an 18-year history of type 2 diabetes, 18-year long history, presents for a routine physical examination. Temperature is 36.9, normal. Blood pressure 158/98. Look, there is a history of hypertension now, and his pulse is 82 per minute and regular. On examination, the physician notes a non-tender pulsatile mass in the mid-abdomen. A plain abdominal X-ray film with the patient in the lateral position reveals spotty calcification of a markedly dilated abdominal aortic wall. I'm sure a lot of the students have already made the diagnosis here. Which of the following is most likely pathogenetically related to this patient's aortic disease? But first of all, we should make sure which disease is this. What is the pathology here in the aorta?
Aneurysm.
Abdominal aneurysm.
Exactly. This is abdominal aneurysm. Now look at the clues for that aneurysm. Pulsatile mass. This is the strongest clue there, pulsatile mass. And this pulsatile mass is very typical, you know, when I put two of my finger over the mass, the both finger will separate away from each other. This is the hallmark of aneurysm. Never forget this. Sometimes what happens? A big mass is just present on the superficial part of the abdominal aorta. The pulsation from the abdominal aorta may transmit to that mass, but during that time, my finger will not separate away from each other. They are just elevated. But in this case, they are elevated and separated. This is a very important physical finding of aneurysm. It is present in the mid-abdomen. Abdominal X-ray shows calcification. This is one of the hallmark of abdominal aneurysm. Now, your question is very simple. What pathological process is the most common cause of this abdominal aneurysm? Atherosclerosis, cystic medial necrosis, Kawasaki disease, monkey bug arteriosclerosis, or syphilis? Okay, what is the answer here? It is
A.
atherosclerosis, or
Atherosclerosis.
A. Exactly, it is atherosclerosis, because atherosclerosis are the most common causes of abdominal aneurysm. Other things, okay, are also a part of aneurysm process, but are you know, abnormality of the blood vessel process, but they are somewhat different from the case. The correct answer is A here. Okay, so you can go through this you know, later on, because I will load this you know, video in the YouTube later on, so you can go through this abdominal aneurysm. You know, the most common cause is atherosclerosis here. And what are the risk factors for the atherosclerosis in this case? Your teacher may ask question like that. Now let's pick the risk factor here. One is age, another, okay, another is a hypertension and smoker. So these are the different risk factor here. Apart from that, okay, some other choices you need to rule out also, and the correct explanations are given here. So we're talking about the clinical cases discussion. So let's proceed further. This case is all about a 3-year-old girl. Okay, her age is 3 years. Is seen in the emergency department with acute abdominal pain. She has a 5-day history of vomiting and abdominal distension. Now see this straightforward case. The diagnosis is very simple here, and she has not passed any stool during this time and during the past day, and has been vomiting bilious material. Now, if we combine all these important clues, you know, this is a straightforward case of acute intestinal obstruction. Look at the history. 5-day history of vomiting, abdominal distension, constipation, abdominal pain, and the vomiting is a bilious type. Now, bilious type of vomiting is only present when the obstruction is distal to the second part of the duodenum. Always remember that, because the bile duct opens at the second part of the duodenum. Okay. On physical examination, she is lethargic. She is lethargic. Probably she is already dehydrated, with a firm and tender abdomen, and peritoneal signs are present. Peritoneal signs are already present in her. Means parietal peritoneum is involved. She is immediately referred for laparotomy for suspected diagnosis of intussusception versus volvulus. They are afraid, okay, there is a rupture of the viscera. What is intussusception, by the way? What is that?
So it's the telescoping of the proximal distally, proximal part of bowel distally, sir.
Exactly. Very good. Well explained. It is called telescoping of the proximal segment of the bowel into the distal one. Telescoping means the proximal segment is, you know, going inside the lumen of the distal one. It is going further downwards into the lumen of the distal one. So there are two main problems here in case of intussusception. One, It leads to intestinal obstruction, definitely. And another one is ischemia, because it is dragging the blood vessels along with it. So there is a twisting of the blood vessel, which can result in decreased blood flow. That leads to ischemia and necrosis. Okay, so intussusception is a serious condition. Volvulus is a twisting of the bowel around one axis. So this also leads to ischemia and a death of the intestinal, loop, whatever is affected there. Now, what they have found here now, okay, this is just a suspicion though. At surgery, see this? At surgery, approximately 20 centimeter of the small intestine is found to be markedly distended and is resected. So probably it is, distended and a bit dead also. So it is resected. The section contains a tightly knotted ball of the nematode that are about 15 to 35 centimeter in length. Now we have found the cause of this intestinal obstruction, that is the ball of nematode, which are quite long. Look at the length of this nematode, 15 to 35 centimeter in length. That is a clue for your answer here. The worms have tapered ends without hook, and the worms are most likely which of the following. So can you choose which one of the following worms are responsible for this acute intestinal obstruction? Yes. Is it Ankylostoma duodenale? Is it Ascaris lumbricoides, Enterobius vermicularis, Strongyloid stercoralis, and Trichuris trichura? Which one of that?
Caris lumbricoides.
Okay, he's saying Ascaris lumbricoides. Why?
Sir, because of the length is given, so SK will be very long, and SK can cause so many problems like obstructive jaundice, intestinal obstruction, and malabsorption syndrome.
Absolutely correct. Very good. That's the point. Okay, that's why I clearly told you there is a clue for you. The length of the worms, 15 to 35. Ascaris lumbricoides are the longest of the nematode. All of these are example of nematode actually. Nematode means roundworm. Okay, among them the giant roundworm is called Ascaris lumbricoides, and that can give rise to a lot of problem. He's right. One of the problem is just like this, which we are seeing here, acute intestinal obstruction. Another is obstructive jaundice. They can climb up towards the common bile duct and can cause obstructive jaundice also. Okay, and they can cause malnutrition in the child because they are quite long worm and they can consume a lot of nutrition, whatever the child needs. So child suffers from malnutrition, and sometimes they can come out of the GI tract through the vomiting or while the child passes stool. That will make our diagnosis quite easier. This is a very interesting case. Look at the answer now. The correct answer is B. Ascaris lumbricoides is the only parasitic worm that is likely to cause intestinal obstruction, and then only if the worm burden is high, means ball. When they are high, they form a ball-like mass, and that ball-like mass may obstruct the intestinal flow. The description given of the worm in the case presentation is typical. All of the other worms listed in the choices are also nematode or roundworm, but they don't cause intestinal obstruction, like hookworm. Hookworm, okay, the first option, Ankylostom duodenale hookworm, it causes anemia, that is iron deficiency anemia. Apart from that, not much problem. The other options, let me go back. The other option, Enterobius vermicularis, is called pinworm. It causes very itchy type of problem in the near the anal canal, especially in case of children. Strongyloid stercoralis causes some GI problem, and Trichuris trichura also causes some GI problem, but they are not very serious. Okay, so with this, let me start another type of clinical scenarios to you. Okay, now see here. This is clinical problem discussion part 4. let us see how far we can go here. So all of you, please solve this. Number one, let me highlight the important points. A college student received an injury as a result of being tackled in a football game. So this is a football game injury. After the game, the student was treated at a local hospital and was found to be unable to abduct and rotate the left arm at the shoulder, flex the elbow, and extend the wrist of the left side. So most of the problems are happening on the left side. Okay, so what are the problem now? Unable to abduct and rotate the left arm at the shoulder. Abduction of the shoulder is gone. Okay, flexing the elbow is also a problem, and extending the wrist is also a problem on the left side. Upon further examination, testing revealed depression of the biceps reflex of this limb. Biceps reflex is diminished, but the reflex activity involving the other limbs was normal. So the most likely site of the injury in this case is, that is the question, is it in the precentral gyrus? Is it in the basilar pons? Is it in the ventral horn cells at C1? Is it nerve roots of C5 to C6? Or is it at triceps muscle? What do you think? Anyone?
Option D.
Yes?
Nerve root of C5 and C6.
Can you elaborate on that?
Sir, because patient is unable to abduct and rotate the left arm at the shoulder. So most probably that the deltoid muscle, the nerve supply to deltoid muscle is affected. And also flexion of elbow is lost and extension of wrist is lost. And most importantly, that bicep reflex is lost. So the root value of bicep reflex is C5 and C6.
Excellent. Okay, very good. So he has a a good knowledge regarding this, and he's absolutely correct. There's no even one point which I can pinpoint there and say you are wrong. Absolutely. Now see here, this is a example of C5 to C6 injury. Now all of these muscles, whichever he has mentioned, were supplied by C5 C6 nerve root. Yes, deltoid muscle is supplied by axillary nerve, and axillary nerve has the root value of C5 to C6. No doubt about it. Biceps reflex, the root value is C5 to C6. These are a strong clue for you. Okay, and when deltoid muscle is paralyzed or loss is nerve uh, uh, supply, then abduction of the shoulder cannot occur. Flexion of the elbow is the job of different muscles which are present on the anterior compartment of the arm, okay, like brachialis muscle, even biceps muscle. Okay? These are also paralyzed in this case. So typical answer is C5 to C6. Precentral gyrus, okay, precentral gyrus is a motor cortex. Motor cortex. If something has happened in the motor cortex, these are not the clinical clues which are given to you. The clinical clues will be upper motor neuron problem. Probably they say the reflexes are hyperreflexia. Okay, there is an increased tone, something like that. But then these are the things not given here. So this is the very straightforward case. Basilar pons, again, upper motor neuron features would be there. Ventral horn cells at C1. Okay, it doesn't form a part of brachial plexus at all. And triceps muscle, there is nothing wrong with the triceps here. This is a neurological case, a little bit difficult for many students, but if you pick one or two clues from here, answer is very easy. So the answer is D. In this case, disruption of the root fiber of C5 to C6 involve the component of the brachial plexus and affect muscle group like deltoid. We have nicely picked that here, deltoid muscle. supraspinatus and infraspinatus. This is infra, okay? Biceps brachii and even flexor carpi radialis. So these are affected so that the problems which are exactly explained in this case happen. See this. Lesions involving the cerebral cortex, that is precentral gyrus, or the pons, especially the region of the pyramidal tract, would produce a UMN paralysis, upper motor neuron paralysis, which would include hyperreflexia and hypertonia. Look at the very important point which are highlighted in the explanation. So why these are important now? Because the next case may be based on this type of physical finding. And if you present prepare only one way, then other case would go wrong. An LMN paralysis involving the ventral horn cells at C1 would not affect the brachial plexus. So this is out of the question. And triceps muscle is the wrong option here. Let's move on. Number 2, here. A 60-year-old female, so this is the age, 60-year-old woman, was hospitalized with a severe respiratory infection for several weeks. Afterward, she displayed symptoms of myalgia and weakness of the lower limbs. So this is a weakness of the lower limb again. Myalgia means muscle pain. In addition, she also showed loss of muscle tone and some flaccidity with loss of tendon reflexes. Now, what is this? Is this upper motor neuron lesion or lower motor neuron lesion? What is the conclusion here? What type of disease is this?
LMN.
Exactly. This is LMN. That's what we are discussing right now. See this? Loss of muscle tone. This is hypotonia, which is also known as flaccidity. Tendon jerks are diminished or even absent, and there is weakness of the muscle. All are features of LMN or lower motor neuron type of lesion. Examination also revealed a weakness of facial muscle. This constellation of symptoms progressed for approximately 2 weeks and persisted for more than a year, at which time recovery took place at a slow rate. So it's a progressive type of illness, okay, and a bit of recovery was also taking place, but at a very, very slow rate. There is also some demyelination coupled with lymphocytic inflammation at the site of demyelination. So demyelinating polyneuropathy, they have already given very important clue here, and this is done by lymphatic infiltration there. The most likely cause of this patient from this list, okay, here, is it myasthenia gravis? Is it muscular dystrophy? Is it multiple sclerosis? Is it Guillain-Barré syndrome? Or is it lumbar disc prolapse? Who want to take this case? Yes?
Sir, I think this is Guillain-Barré syndrome.
Okay, give reason, please.
Because, sir, from the typical history, and this usually, sir, Guillain-Barré syndrome is like produced by upper respiratory infection, and there's a syndic weakness or paralysis.
Good. Anything else you want to say? Very good. The reason you have given is absolutely nice. Okay, Amro has spoken. Anybody else? Anybody?
Yes.
Yes, Yunus.
Sir, she is female, and the gender is also, sir, important because GBS is an autoimmune disease which occur mostly in female and also precipitated by infection. And there is all lower motor neuron signs, and the clearly demyelination of the neuron cells.
Very
so
good.
that is a clue for GBS.
Very good. Both of them are absolutely correct. This is a clear-cut case of Guillain-Barré syndrome. Now look at the other clues here, but they have already picked them. Female sex, Okay, this is a cause of the disease, respiratory infection for several weeks. Okay, though a GI infection is the more common cause for Guillain-Barré syndrome than respiratory infection. Campylobacter jejuni infection is considered a very common one, but nevertheless, Mycoplasma pneumonia can also be included there. Okay, and clues are of the lower motor neuron disease like loss of muscle tone, flaccidity, and loss of tendon reflexes, typical of Guillain-Barré. And it takes a long time for the patient to recover. Yes, and the recovery is also not complete. That is also true. And there is a strong clue of demyelination, which is caused by inflammation, and that is by lymphocytic infiltration. So Guillain-Barré syndrome is a straightforward answer here. Now see here. So let's go through a bit of explanation for the sake of other students. The answer is D, or Guillain-Barré syndrome, which is an acute polyneuropathy whose occurrence frequently follows a respiratory infection or GI infection both. It results in myalgia of the lower limb, loss of muscle tone and tendon reflexes, and some flaccidity. The disorder can also affect the seventh cranial nerve, which is also given here. Okay, facial weakness is also a part of that. The disorder can produce diffuse demyelination of the peripheral nerves with an increase in lymphocyte present at the site of demyelination. All the clues point towards the same thing. But your teacher may ask you why this is not a case of multiple sclerosis. Now remember, multiple sclerosis only involve central nervous system neurons or structure. And clearly here, the peripheral nervous system is involved. So multiple sclerosis is ruled out straightforwardly. Okay, this is not a case of multiple sclerosis because peripheral nervous system is involved or affected. Other clues are very easy to exclude. Let's move on. Number 3. So please, all of you focus here. A 46-year-old man finds that over a period of time, he has progressive bilateral weakness of both upper and lower limbs. So this is a progressive bilateral weakness of both upper and lower limbs, beginning with the muscles of the hands, the small muscle of the hand. However, testing reveals that the sensory functions appear normal. So this is a pure type of motor disease where sensory nervous system is not affected at all. Eventually, this individual is found to have wasting of the muscle, fasciculation, and evidence of upper motor neuron dysfunction. You see this? So fasciculation is a feature of lower motor neuron dysfunction. Remember that. Wasting of a muscle also seen prominently in lower motor neuron. And there is upper motor neuron dysfunction as well, which is evident by increase in tendon reflexes. So combination of upper and lower motor neuron features together. After a few additional months, the patient develops facial weakness and inability to swallow, which is dysphagia. Further analysis reveals abnormality in the electromyogram of the upper and lower extremity. Again, a feature of lower motor neuron. Denervation atrophy, feature of lower motor neuron. However, the CSF remains normal. So this patient is most likely suffering from which of the following disorder? Is it multiple sclerosis? MS means multiple sclerosis again. Amyotrophic lateral sclerosis or ALS, poliomyelitis, myasthenia gravis, or a stroke, that is cerebral cortical stroke. Yes?
B.
Okay. B. Can I ask any other student who has not, taken participation, in this? Anybody else? Yes? Are those guys just open their, connect here and disappear? I want to hear some more voices here. Anybody? Yes? Okay. No answer. So the guys who are taking active participation, okay, please go ahead. Yes?
That it's maybe because it's power motor,
Mhm.
it's power They were motor loss of functions with its occur in amyotrophic lateral sclerosis commonly. In other, there are sensory losses also. I mean, for multiple sclerosis, myasthenia gravis, and cortical stroke.
Okay, so Khatir is saying it's amyotrophic lateral sclerosis. Okay, good. Okay, I'll come to you. Anybody else?
Yes,
Yes, sir.
this is a case of amyotrophic lateral sclerosis because this is a motor neuron disease where only motor problem is there without sensory involvement. And plus, there is both upper motor neuron problem and lower motor neuron problem. Like in this case, there is a wasting of muscle fasciculation or the lower motor neuron problem and increased reflexes of upper motor neuron problem. So
Yeah,
the combination of all these things.
very good. Okay, so that is a correct answer. Both of them are right. It is a case of amyotrophic lateral sclerosis. Now, what are the clues provided here? The combination of upper motor neuron and lower motor neuron features together without any sensory involvement. So this is a motor neuron disease. Only motor nerves are affected here. And then it is a progressive type of disease, see this involvement of the face, difficulty to swallow. So the weakness is progressive in nature. A typical case of amyotrophic lateral sclerosis. Multiple sclerosis, of course, have some sensory problem as well as motor problem, and mainly the central nervous system neurons are affected. This is also a type of demyelinating disease, multiple sclerosis, autoimmune disease as well. Poliomyelitis is caused by virus, poliovirus. This is a typical case of lower motor neuron disease, poliomyelitis. Okay, asymmetrical paralysis of a particular group of muscle. So why upper motor neuron should be affected in polio? So it is easily ruled out. Myasthenia gravis never presents like this. Myasthenia gravis has typical presentation. Towards the evening time or towards the late time of the day, the patient feel weakness. And some autoantibodies, those type of clues would be provided to you. And a stroke, okay, only have upper motor neuron features, not the lower motor neuron one. So neurology, if you know the concept, it is quite easy. Now, see here for the other students, let me go through this, explanation once again. The answer is B here. Amyotrophic lateral sclerosis is characterized by progressive loss of motor function. First, seen as a weakness in limb muscle, especially those of the finger, and later of the other limbs. Sensory functions are not affected. Over time, there is wasting, there is atrophy, and there are fasciculations of the limb muscle followed by upper motor neuron sign. So combination of both lower as well as upper. Electromyogram abnormality can also be observed of the upper and lower extremity. This is a feature of lower motor neuron features. Now, other points are also highlighted here. In multiple sclerosis, there is also sensory loss, such as loss or blurring of the vision, as well as bladder problem. Poliomyelitis and myasthenia gravis involve lower motor neuron symptoms, while a cerebral cortical stroke would result in upper motor neuron disorder without lower motor neuron sign. Okay, so these are quite an important point. Now, for the students, okay, who are relatively, weak, or they are not showing that much interest in this type of cases, please remember one thing. These, discussion which I am doing here are very, very important one from your exam preparation, perspective. Don't be surprised if your teacher asks the same question which I am asking to my students now. Like, what are the differences between upper motor neuron sign or lesion and lower motor neuron lesion? Now, if you pay attention here, this question is very easy for you. See there, wasting of the muscle, atrophy of the muscle, fasciculation, areflexia or hyporeflexia, or flaccidity. All of these are features of lower motor neuron paralysis. Whereas, okay, wasting can be seen in upper motor neuron lesion also. Okay? But in comparison to lower motor neuron, it is not very prominent. Then hyperreflexia, okay, brisk type of reflexes, Babenski sign, isn't it? Spasticity. These are feature of upper motor neuron lesion. Now let's move on. Now let's go to number 4. Now I have included some very easy and straightforward type of question now. Okay, so not much discussion is necessary. A 32-year-old woman presents with intermittent headache lasting around 24 hours, associated with nausea and sensitivity to movement, light, and the sound. The frequency of this headache is 4 or 5 per month. Now, you already know the diagnosis here. What is the best prophylactic treatment to give her to try and prevent the headache? So question is prophylactic treatment, okay? Please, sometimes a student who already know the diagnosis, fails to pick the correct answer because he is in hurry, he is not reading the question properly. So you just read what is the best treatment like that and choose the answer which may not be appropriate. So please read the questions very carefully, always. So is it sumatriptan? Is it paracetamol? Is it verapamil? Is it ibuprofen or is it propranolol? Anybody?
E.
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 It's propranolol, right? It's E. Exactly. Okay. No need of any discussion. What is the diagnosis you have made here? What is the diagnosis?
Migraine.
Migraine.
Exactly. This is a case of migraine headache. Very common type of headache. Migraine headache. Okay. Female. Migraine is quite common in female once again. Okay. These are called phonophobia and photophobia. See this? Light and sound sensitive. Photophobia and phonophobia commonly have nausea and vomiting as well. And after they develop vomiting, the headache decreases. They want to go inside a dark room and want to sleep. They don't want to be disturbed by other people during that time. They will be quite irritable if that happens. This has got a very strong family history as well, migraine. Okay, and the typical episode lasts up to 3 days. Okay, and many episodes occur per month. Now we have 2 types of treatment here. One is treatment of the acute episode, that is we give painkiller, and another one we postpone, okay, the coming episode, means we push them further away, and that is done by prophylactic treatment. Understand the concept here. This is the prophylactic treatment. So for the treatment of acute episode, we can give sumatriptan, we can give paracetamol, and we can give ibuprofen. Verapamil is not used usually in the treatment of migraine. Only one option, propranolol, is used for the prophylactic treatment here. Okay, so the answer is E. Let's go to the another case here. A 22-year-old woman presents with intermittent headache that occur infrequently around once every month and last for around 24 hours every time. They are usually unilateral. See this? Unilateral, throbbing, okay, throbbing in nature with associated nausea, photophobia, and phonophobia. Which of the following drugs might be used in treating an acute attack of this type of headache? The same discussion I'm doing right now is given as the another case. Now, what is the diagnosis once again?
Cluster headache.
Migraine.
Migraine headache.
Now, see that? Is it cluster headache or is it migraine?
Migraine.
It is migraine.
Migraine.
Yes, it is migraine. Okay. For cluster headache, you should have some other clues like some rhinorrhea or some secretion from the nose, a bit of congested sclera or congested eye or red eye or something like that. severe type of headache and multiple episodes, something like that would be given. So this is again a case of migraine. So the answers are straightforward here. What are the answers? Can you pick the correct answer from the list? Yes?
A.
A.
A. And one more.
A and C.
Exactly. C also, see this, aspirin also can be given to the patient. This is NSAID. Yes, A is much more commonly used than C. We know that. Sumatriptan is very commonly used for the acute headache, but aspirin is also another option. So sometimes, you have this type of question, multiple options can be there. Just read in the beginning, if it is only one single answer, multiple choice question, or multiple answer MCQ. So it depends. It depends like that. Okay. Let's move on. Now, question number 6. Let's do this. A 25-year-old woman has an episode of altered consciousness lasting a few minutes. She had no memory of the event, but just beforehand, she developed a sense of deja vu and had a rising feeling in her stomach. What is the most likely cause? This type of cases, if you remember, we have already done in our classes also. During the neurology discussion, we have done that, okay? So this is a bit of, revision for you, but let's utilize this time as a bit of discussion also. So what is this case first? What are they trying to ask? Yes?
Sir, I think this is a case of complex partial seizure.
Complex partial seizure.
Okay, why?
Because the altered consciousness is a feature of complex seizure. And also the deja vu and the rising feeling in her stomach. So I think this is a aura. So all these are features of complex partial seizure, which arise from the temporal lobe.
Exactly. So he has explained it very correctly. She is a 25-year-old female, episodes of altered consciousness lasting a few minutes. Okay. So this is, a bit of loss of consciousness maybe. She had no memory of the event, but just beforehand she developed a sense of deja vu and a rising feeling in her stomach. That rising feeling in her stomach is aura. He's absolutely right. This is called aura. Patient knows beforehand itself that something bad is going to happen. Maybe, I'm going to seize in a few minutes or a few seconds. That is called aura. And deja vu is a typical feature which is associated with temporal lobe epilepsy. And temporal lobe epilepsy, okay, are the commonest cause of complex partial seizure. So you all know what is deja vu, right? What is deja vu, by the way?
Undue familiarity.
Sir, yeah.
Okay. Yes, please explain. Yeah.
Undue familiarity, sir.
Undue familiarity. Okay. Undue familiarity. But if you say like that, people may not understand. So can you give one
Sir,
example and explain?
Sir,
Yes.
sir. For example, sir, if I'm going to some new place and I have that feeling that I've been here before also, or if I'm meeting someone stranger, but I have that feeling that maybe I know this person and I have met him before also.
Good. Yes, Eunice, you want to say something here or same answers?
yes, sir, it's same, sir. Sir, places and people look same, like they meet once before.
Exactly. But they never met that person before, or they never went to that place before. But they have that strong feeling that, I have been to this place. Undue familiarity. Undue familiarity. So this is called deja vu. Okay, this is one of the feature of psychiatric disorder, deja vu, which is seen in temporal lobe epilepsy. So the answer is very easy here. It's complex partial seizure. Now let's rule out some other one after other. Cardiac arrhythmia. Okay, cardiac arrhythmia can lead to syncope because of decreased cardiac output. Okay, syncope can lead to altered consciousness for a few minutes, but these features like deja vu or aura, they don't happen. Postural hypotension again can give rise to loss of consciousness for a brief period. Postural hypotension. While the patient is standing, the blood pressure drops, and then the person may feel dizzy or even fall on the ground. And within a short period of time, the person regains consciousness. Vasovagal syncope, a similar type of explanation here. It's a type of syncope, the most common type of syncope, which is associated with the posture, standing again. And transient global amnesia, okay, is a similar type of description, but again, no aura, no deja vu, those type of things.